All right. So today we've actually moved to the very end of Edinger, and this section is called comorbidities. So through the next couple of sessions, we're going to be talking about sort of diseases that commonly happen concurrently and the kind of hiccups that we hit as we try and manage them. And particularly what we're talking about today, heart disease and kidney disease, both happen in older animals commonly. And there's management of renal disease is sort of contraindicated with late stage heart disease and vice versa. So they can be a little bit tricky to manage. So I wanted to talk a little bit about the pathophysiology of why they kind of contradict each other or why they might exacerbate each other, and then talk about different sort of management strategies a little bit. Does anybody else have anything they want to cover?
Now, it was an unrelated question. I came across the drug ivabradine, and I'm wondering if anyone knows of it.
Studied it, never used it.
Slowing heart rate without a negative inotropic effect.
Yeah. Has anybody heard of it or used it? Is it commercially available?
I presume so. I was talking to a friend of mine who was an anaesthetist in CSU.
Oh, I think it's available in the US. I don't think it's approved here. So essentially what it is, oh my gosh, this is really going to stretch me. I can't remember the mechanism of action, but the idea of it is that it's similar to pimobendan in that it's a calcium sensitizer, so it makes the heart more responsive. The smaller amounts of calcium result in the same amount of systolic improvement in contractility and relaxation. So they release the calcium more easily to release the relaxation, so it improves diastole and systole. The trouble with all drugs that we've got to date, which improve contraction, that speed of contraction, is that eventually they can cause fatigue in the heart. And ivabradine is one that the mechanism that it uses shouldn't fatigue the heart. You know, that's the sort of the reason why we don't like to start pimobendan too early, like as soon as they get a murmur, is that it might fatigue eventually. But ivabradine is supposed to kind of overcome that. So it's very promising, but we just don't have data on it. Or didn't last time I looked into it, which, to be fair, was a while ago. Yeah, very exciting if they're starting to use it if it's commercially available in the US, because it means it will follow for us pretty soon. Did your friend say that they were using it were using it with patients, or just talking about theoretically?
Physiology at the moment, so it could well be theoretical.
Yeah, okay.
But he did tell me the action of it, and of course it went in both ears and got lost in the vacuum. Of course, it was complex biochemistry, I thought.
It's pretty complex.
Sodium channels, he said, it affected.
Sodium channels. Gosh, I hope I haven't been talking about the wrong drug.
Yeah. Anyway, I'll have to get him to write it down for me so I can send it.
Good. Yeah, maybe if we can send that around in an email. So if you send it to me, Jeff, then I'll distribute it through the group that signed up for tutorials.
Yep. Right.
Excellent. So for managing concurrent renal and heart disease, there's a couple of good references out there. There was one written in 2015, and not much has changed since then on this topic. And there's been a kind of bit of a conference tour where one of the sort of well-known cardiologists has spoken on this. So there's quite a few conference proceedings and things. And I think there's a more recent article, 2022, but I can't access it. So if anybody's after more advanced reading on this, then go for it. And in exciting news, there's a new Edinger out early next year. So Josh is paying attention all of a sudden, just in time for exams. I hope you're going somewhere fun, Josh.
Sorry, what was that?
I hope you're going somewhere fun.
Yeah, heading to the snow.
I'm jealous.
Oh, there is some now, is there?
but I've got very bad reception right now, so I might be in and out. Sorry.
Yeah.
No, it's fine. I'll ask you all the hard questions.
Okay.
Hi, Alex. All right, so let's start by talking about when we have heart disease, what compensatory mechanisms or sort of what parts of the pathophysiology of progression of heart disease would compromise renal function?
Well, basically cardiac output, because the kidneys take 25% of it.
Good, excellent. So decreased renal perfusion due to decreased cardiac output. Excellent.
Isn't there sympathetic activation? Because I knew this for members.
It's
But
amazing how
basically,
quickly it
like,
goes.
oh, I know. But basically, I think because we have decreased cardiac output, the sympathetic nervous system releases the, I can't remember. But then something like that.
Yeah, so it is the sympathetic nervous. You're exactly right. So activation of the sympathetic nervous system. There's only really two really significant hormones in the sympathetic nervous system. Hormones, like neurotransmitters, I guess, is probably more appropriate.
Oh, yeah. Noradrenaline and
Right.
adrenaline. Yeah.
Yeah, exactly. Yeah.
And
so,
I think I remember that. Oh, sorry, you go.
No, you go.
Oh, I think noradrenaline activates like the beta adrenergic receptors, and that causes an increase in heart rate and also RAS activation, and
Ooh.
also can cause aldosterone, or actually, no, sorry, renin secretion production, which then feeds into RAS activation.
Excellent. That's really good. So sympathetic nervous system, let's go back to just the impact of upregulating sympathetic nervous system activity. We've got beta receptor activation, and the beta receptors are on the heart muscle itself. What other adrenoreceptors might be activated in early congestive heart failure? The ones on the heart themselves, and then what about the rest of the body? What is one of the side effects of propylene?
An alpha blocker, I think.
Alpha agonist.
Agonist.
Yep. So the alpha receptors.
Yeah,
Good. Excellent. So what happens when we get vasoconstriction to blood pressure?
you get higher blood pressure.
Good. Excellent. So the activation of the beta receptors is compensatory. That's a very functional response to a decreased cardiac output, right? So you want to increase the heart rate and strength of contraction, thereby increasing cardiac output if cardiac output drops. So that's a perfect response. But what's a kind of off-target pathologic response is vasoconstriction in response to sympathetic nervous system activation, which is going to exacerbate afterload, isn't it?
Yes.
So if you've got a leaky mitral valve and the ventricle's pushing against harder afterload, so it has to work harder to get the blood out of the heart, what's going to happen to we call it the regurgitant fraction. So ejection fraction, the fraction, so if you've got 200 mils in your left ventricle and it's squeezing, you've got an ejection fraction, the percentage that goes out the aorta and the percentage that goes back through the mitral valve. So what's going to happen to the regurgitant fraction if you've got increased afterload?
Does it increase it?
Yeah, it does, exactly. So hypertension will exacerbate regurgitation, essentially. So you're going to end up with increased afterload will exacerbate the mitral regurg. And obviously mitral regurg is the main thing that causes congestive heart failure in patients that we see. Good. So that's decreased cardiac output first, which causes sympathetic nervous system activation first. And then we get increased cardiac output, increased heart rate with the beta receptor activation, and then a little bit of hypertension. And then we talked about renin, stimulating renin release. What is it that stimulates renin release?
Part of it's for cardiac output. It's one big part of it. So you get your baroreceptors just don't pick up that pressure. So
which baroreceptors where?
I think the aortic ones. Is that what you asked?
Yeah, it is. You probably know more than me though, so it's intimidating, but I think it's in the kidneys.
Probably.
It's the juxtaglomerular apparatus.
The
Is it the
juxtaglomeralar apparatus.
Macula densa, yes. Yeah, so I think
There's carotid ones as well, I think. Or
baroreceptors. So I think the baroreceptors stimulate the sympathetic nervous system. When you've got decreased aortic pressure, that then is the the sympathetic nervous system activation. I'm going to have to look into this. There's going to be an email coming out with the mechanism of action of the vabradine.
But
and
ultimately neurohormonal activation and increased volume.
Exactly. Yeah. So what we get when we get decreased renal perfusion to the kidneys, obviously, decreased perfusion to the kidneys, a drop in pressure within that glomerulus, and that's then going to cause renin release, which is going to do what?
That impacts on the angiotensin system.
Renin, aldosterone, angiotensin activation.
Yeah. So let's break that down. So renin will cause aldosterone secretion via activation of the mineral
Angiotensinogen.
So renin directly stimulates the adrenal cortex to produce aldosterone. So that's a direct thing. What's the mechanism? What does aldosterone do in the body?
That regulates volume, and then also potassium secretion, like regulates that.
Yeah, regulates it in what way?
I think you have with the secretion, it plays a role of potassium, like how much is secreted.
Definitely with potassium. With sodium, though, will it cause sodium retention or excretion?
Retention.
Good. Excellent, excellent. So we've got sympathetic nervous system activation, contracting the vessels around the blood volume. And then we've all of a sudden got sodium retention, and we know water follows sodium. So we get an increase in circulating volume in the presence of activation of those adrenal receptors. So we've got two mechanisms of hypertension acting together. So we've got another mechanism of volume overload happening. And then we've got activation of angiotensinogen to angiotensin, don't we? So we've got angiotensin 2 then causing, what does it cause?
Vasoconstriction.
Yes. So even more, they're just nailing all of those peripheral arteries. So lots of different mechanisms of both increased circulating volume, but also increased vasoconstriction. So if we then say, what impact is that going to have on our kidneys? It's all sort of compensatory. The whole idea of all of these responses is to improve renal perfusion. Is that a good thing for the kidneys in this situation?
You get renal hypertension, I guess,
Yeah,
excessive renal blood flow.
exactly right. Yeah. And what does that do to the kidneys, like sort of longevity wise?
I guess you get scarring and inflammation, probably scarring, protein loss.
Yeah. Sorry, Bron, I'm not laughing at you. My daughter's learning to play drums and my son's learning to play a keyboard, and there's a full band playing downstairs. I don't know if you can hear it.
That's awesome.
It's pretty fun. It's just getting louder and louder. They're just like cranking the volume. Good. So exactly right. So we're going to get some scarring of the glomerulus. Now, we did a few tutorials and went on a deep dive of what happens when different components of the kidney get injured to the nephrons. So when you lose a glomerulus because a scar forms or a clot forms or the endothelium gets damaged and it gets blocked, what happens to that nephron? Dies. Is that what you said?
Mm-hmm.
Yeah, it dies.
So then the other nephrons have to take over that workload. And
Exactly. And the kidneys are working doubly as hard because the GFR is still really high because they've got increased volume in circulation. So we've got the same, or we've got an increased volume, or same or increased volume going through fewer nephrons. And those kidneys are then trying to reabsorb that sodium under the effects of aldosterone and all that water. So those nephrons have got a big job to do to try and reabsorb that. So if you think we've got kind of, say we've got 50% renal function remaining, older animal, there's been some nephron loss throughout the lifetime, we've got 50% remaining, and all of a sudden a chordae tendineae ruptures or something like that, cardiac output drops dramatically, all of those mechanisms to retain fluid kick off. And we end up with a vastly increased blood volume going through 50% of the nephrons. Remember when we talked about the kidneys being like almost in a locked box, and there's the vascular space, the nephron space, the interstitial space, and they've all got to fit in this locked box. It's kind of like the intracranial space. So if one space expands, it squashes the other spaces. So if we've got fluid retention, if we've got increased volume in our system, which space is going to expand?
interstitial.
Good, excellent. So volume overload causes interstitial, what's the word?
Edema.
Good, interstitial edema, excellent. So we've got all these mechanisms with heart disease, which both decrease perfusion to the kidneys, but also lend themselves to development of interstitial edema. And if that nephron gets squashed and nothing's flowing through the middle of it because there's interstitial edema pushing around it, or if that interstitial edema decreases nephron perfusion because that vascular space is squashed as well, what's going to happen to the nephron?
Dies.
Dies, exactly. Poor nephrons. So you can see how fragile the kidneys are with to nephron loss with the kind of necessary compensatory mechanisms we see with decreased cardiac output and congestive heart failure. Now, what if we kind of now flip this around and say, if we've got chronic renal disease as the primary kind of disease, what mechanisms of chronic renal disease might impact the heart?
You probably get hypertension.
Mm-hmm.
Well,
Yep, excellent. So similar mechanisms, really. Decreased renal perfusion, renin-angiotensin. And what is the other mechanism for fluid retention with renal disease? if you think about the kidneys as a sieve and you block half the sieve because half the nephrons are lost, is the water going to flow through as quickly?
No,
No.
sure.
So volume retention, fluid retention with chronic renal disease happens when we get nephron loss to the point that it can't keep up. There's not enough nephrons to get rid of the volume. And that's usually very slowly progressive and compensated. But what happens when you put a dog with decreased, like acute renal failure on fluids?
They can either become like, are you talking about like polyuria, like, is that polyuric?
Yeah. Yeah. So the sort of phases of renal disease are polyuria and then
Polyuria.
yeah,
And then
where they're not keeping up with oliguria, they're not producing enough to get rid of it. And then
anuria.
exactly, yeah. So we can get, particularly in situations where we're managing these patients in an acute crisis, and sometimes we have to give them fluids for their renal disease, but we run a real risk of volume overloading them if we're not really monitoring that they're excreting what we're putting in.
Wow. Does that happen even in like, yeah, I kind of thought of that as really happening in acute renal injury, but that's something that you could potentially happen in a decompensated chronic renal failure patient.
And what is decompensation? It's acute renal injury, isn't
Yeah.
it?
Mm, wow.
Yeah. And particularly in these patients, we'll talk more about how the kind of therapy of heart disease will exacerbate renal disease, but we're causing acute kidney injury by completely crippling the kidney's ability to retain fluid, aren't we?
Right.
It's a bit of a deep dive.
Good.
I sort of was like doing some reading for this and just thinking there's not actually that much to talk about that we haven't talked about already, but this stuff's so good to revise in the context of like happening together, I think. Okay, so we've got, it's going back to our first question, what kind of impacts of chronic kidney disease would exacerbate heart disease? And we talked about hypertension, we talked about volume overload. What will that actually do to the heart?
Will it
Increase
increase the
preload?
preload?
Say again, sorry.
Will it increase the preload?
Increase preload, yeah, exactly. Yeah. And what will that do?
Activates the Starling forces and increases the strength of contraction.
Should do in a heart that has capacity to increase strength of contraction. What about a heart that's just so tired? DCM. Or
Backflows. Does the backflow?
We'll say again, sorry, it just dropped out.
Oh, sorry. Does it backflow?
Yeah.
Into the.
It's just heart can't keep up with all that volume, can't get it out fast enough. Cardiac output's already dropped, we've already compensated maximally, and all of a sudden we've got increased preload. Where's that if we've got mitral valve disease or left-sided systolic failure of cardiac output? Where does that fluid back up to?
Atrium.
Lung, atrium,
And then go to the lungs.
pulmonary, veins, and back into the lungs. Good.
That's left-sided, but what about increased preload? Would you get right-sided failure and backing up to the liver? But I can't say that that's an experience I remember.
If they've got primary tricuspid disease, then absolutely we see backing up into the liver. And where else does the fluid go?
Pleural space.
Can be pleural, particularly in cats, yeah?
Can you go to the pericardium?
Yeah, and particularly in cats as well. They're really good at just putting fluid everywhere. But when in a dog with right-sided congestive failure, where does the fluid go?
Peritoneum.
Yes, exactly. So we get increased venous pressure through the liver, like Jeff said, And then once the liver's just chockers and we get increased portal pressure, we then see ascites develop, don't we? So
ascites doesn't normally develop in renal failure and cardiac failure like that, though, does it?
if you've got right-sided congestive failure, yes.
Yeah.
So if you've got left-sided failure, the right side just operates under such low pressure that if the valves are functional, if you don't get a whole heap of blood going backwards through that right side of the heart, we don't really notice the increased preload or the increased volume. Also, the portal venous system is so, what's this word?
Something like
Plastic.
or something.
Elastic. It can accommodate such a variety of volumes. It's really flexible, particularly in dogs. It's definitely, maybe it's particularly in cats, but the portal system in both species, it can accommodate a lot more pressure. So we don't actually see clinical signs of congestion on the right side until it's really advanced. So right-sided heart disease generally is a lot less clinically dramatic than left-sided heart disease because there's just so much more capacity in the system. That's a good word. So say we've got increased preload, which is going to increase the incidence of edema or fluid going outside of the vascular space into the interstitial space. What else have we got? Let's move on to another thing that we see. If you were doing a blood test in a cat with kidney disease, what would be something that you look for that would give you an indication whether it's chronic or acute?
Anemia.
Anemia, good. How will anemia impact heart disease?
A low oxygen carrying. I mean, that's more lungs.
Good. So if you've got an anemic patient, how do you tell whether they're clinical for that anemia?
Oh, yeah. Tachycardia.
Tachycardia, exactly. Muscles still have the same oxygen requirement. The organs in the body still have the same oxygen requirement, and there's less blood carrying it. So if even with a very small drop in PCV, the heart has to work harder to deliver that blood. So it increases the workload on the heart. What else happens to blood when there's less red cell bulk in it? Like, what is it when you taking the blood in the syringe? What does it feel like? Does it come out easily? Watery, exactly.
Less,
it's
not viscous.
Yes, exactly. Has anybody ever had a dog with profound anemia who didn't have a heart murmur but develops one when they've had an anemia? Yeah.
With murmurs.
Yes, anemic murmurs, exactly. What causes that?
Increased turbulence because it has the low viscosity.
Yeah.
Low viscosity.
Yeah. And where is the turbulence? So most of the time it's mitral. So murmurs are easier to hear when they're high velocity. So if you've got the same volume of blood regurgitating on the left side of the heart as the right side of the heart, because the right side works under low pressure, much harder to hear. So you don't hear a right-sided murmur until it's actually quite a big volume. Whereas mitral murmur, you'll hear quite early because it's going fast and therefore making more noise. So, if you turn a tap on really hard, it's louder than if you turn a tap on softly, right? It's just a pressure thing. So if you've got a valve that it wasn't great, but it was doing the job when you had normal viscosity blood, and all of a sudden you've got thinner blood, you're going to start to get regurgitation where you wouldn't have it otherwise. And if there's already a leaky valve, the regurgitant fraction is going to be higher because it's just the path of least resistance. So anemia is one of the things with chronic kidney disease that if there's concurrent heart disease is definitely worth being proactive in addressing.
Was that because of turbulence that it flows? Like, is that because the blood is just thinner that increases regurg?
Yes, yeah,
Right.
exactly. So it's like again, if we sort of think of the heart valve as a sieve this time, if you're trying to filter custard as opposed to milk, you know what I mean? Like, just think about it going through the hole.
Right. Yeah, okay.
The milk's going to go through the hole faster than the custard is. We want custard blood. We don't really want custard. You know what I mean? I like a visual. Okay. So they're the main kind of pathophysiologic mechanisms I wanted to talk about. So if we've got a patient who's got heart disease and kidney disease, we've got increased sympathetic activation and therefore increased heart rate and hypertension. We've got increased RAS activation and therefore increased blood volume and hypertension, increased preload as well as afterload, if we put it that way. We've got potentially some extra fluid in the extracellular space. So some edema, both in the kidneys, potentially some ascites, potentially some pulmonary edema, developing from our volume overload. What else? And then we've got the renal perfusion effects that come from from having reduced renal function. So say we've got a patient that comes in and we know it's got grade 4 murmur, it's been on pimobendan, it's had an echo, it's stage B2 degenerative mitral valve disease, and it comes in having been vomiting for 3 days, and we do some blood tests and it has a creatinine of 330 and a urea of 40. How are we going to manage that patient?
Oh.
Or what else do we want to look at on our physical exam and things?
But you want to
Did we
look at
say
the
blood
rest
pressure?
to see.
Sorry, go again. I missed.
You can go.
I mean, the basics always to start with, like heart rate, pulse,
Good.
pulse synchrony,
Yeah.
respiration rate,
Good.
sounds,
And what was that last one? Sorry, Jim.
lung sounds,
Heart sounds. Yeah.
lung sounds.
Lung sounds. Good. Yeah.
But I'd like to do chest percussion as well. It's not as accurate, I don't think, but it's helpful.
For pleural effusion.
Yeah. Well,
Yeah.
anything really. Yeah.
Yeah. Anything else we want to check on our physical?
Pressure, blood pressure.
Good. Excellent. Yeah. Any other markers of perfusion that you're interested in?
Oh, the pallor, like mucous
Good.
membrane CRT.
Yeah. Excellent. So this patient has a sinus arrhythmia. Is it in heart failure?
No.
No. Good. So if we've got a dog that, and it's a luxury to know what stage of heart disease the dog was in recently, and whether it's well managed or not. And it's very rare for a dog stressed in hospital to have a sinus arrhythmia anyway. But if you've got a dog who has had an echo recently, is on pimobendan, has a normal respiratory rate, and the heart rate is low, you can treat this dog as a renal dog. There is the only way that a dog with decompensated heart disease would have a sinus arrhythmia is if they're literally about to drop off their perch. Which, yeah, we've seen it a couple of times in a very emergency setting, but these dogs, their mouths are just blue or very pale grey, you know, that I'm not getting any blood look. And their heart rates are low because they're shutting down, in the process of shutting down. But their respiratory rates are high and they've got water coming out their nose and they're puffy with extra fluid. So if you've got a dog with a sinus arrhythmia with a heart murmur, it's definitely not congestive heart failure unless it's really collapsed and very, very unwell. So how would you manage this dog's renal dysfunction?
Well, probably with fluids, but you'd use a low sodium fluid.
Good.
Half S&G is what, 77%, millimoles per liter of sodium, which is probably too high.
Yeah.
Then I can't remember it. There's the name of it is about 42
Plasmolite.
millimoles per liter is probably better.
Mm-hmm.
But if you go under that, you start to get hyponatremia.
It's tricky, actually. It's a really tricky balance to walk. And what fluids we choose depends on the volume status of the dog. So if we've got, this dog's presented with 2 days of acute vomiting, it's presenting hypovolemic. So we're going to deduce that perfusion via mucous membrane, color, stickiness, skin tint, and general appearance of the dog, as well as kind of respiratory rate and things like that. So if we've got a hypovolemic patient, we do need to replace fluids. And typically replacement fluids are high sodium fluids. These are patients where if I wasn't 100% sure they were hypovolemic, I'd probably put them on 0.45%. Like really we have to choose between Hartmann's Plasmolite, 0.45%. That's what we've got available. So if they were very hypovolemic, I'd go for Plasmolite, which is a slightly lower sodium fluid. And yeah, we're not going to use 0.9%, obviously. But if I thought they were fairly euvolemic, I would go for 0.45% in a dog with concurrent renal and heart disease. Why are we avoiding sodium?
The sodium will draw water. You'll increase, you'll exacerbate the volume overload.
Yes,
But
exactly.
would you do this even just with the heart murmur? The dog is not really in congestive heart failure just yet. So would you do it as
I'd be cautious with fluids?
Mhm.
I would be cautious with fluids because these patients are just so much more sensitive to fluids than other patients. So 2 reasons. One is they can't excrete it as well because their kidneys aren't functional right now. And this dog may not have dysfunctional kidneys long term. It might be acute, but we don't know what this dog's ability is to excrete urine or fluid. And then if that dog has any impairment to excretion of fluid, you could overload that heart in the space of 2 hours. So if you did a bolus all of a sudden and it just stayed in circulation, the heart isn't going to have the same compensatory capacity as a healthy heart. And so I am a little bit slower with my replacement volume-wise, so that I give the heart time to accommodate our heart and blood vessels, so sort of down-regulating that sympathetic nervous activation and things, to relax blood vessels to relax a little bit. So I usually don't bolus them. But often we'll use kind of calculate replacement plus maintenance in these patients. How are we going to make sure, because this patient might be polyuric, it might be oliguric, it might be anuric, we don't know. How are we going to know how much maintenance fluid this dog needs based on its losses? What things should we monitor?
You can measure urine output.
Good. That's the most accurate way, really.
The other thing, I'd like to see the electrolytes before deciding on a final fluid.
Isn't it? Yes. Yeah. And realistically, I think sodium's our most important one. Prognosis in an ICU setting for any cause of admission, hyponatremia is associated with more mortality than any other change on blood tests. So if a patient is hyponatremic, they've got a much worse prognosis. So sodium is the most important from a critical care perspective, from a heart and kidney perspective. So that's the one that I'd choose my fluids based on, because pretty much everything else you can supplement in the fluids, right? You can just add potassium or glucose or anything else we need.
What level of hyponatremia are you talking about? Because like even 140 can be hyponatremia. But if the dog is vomiting, like it's not like
It's
if
pretty
you
expected. Yeah.
yeah, so like how are you deciding this is true worrisome hyponatremia? Like is it just a number you're going by or
Well, yeah, pretty much. That study was just like literally the number, but
what
obviously
was the number?
you've had it.
What was the number?
I don't know. I can't remember.
No, no, okay.
Just like hyponatremia based on reference intervals of that lab, I would say.
Okay.
But if we like, I guess studies like that look at this huge population of dogs. We've got a vomiting dog who's probably got polyuria based on having chronic kidney disease, or we could probably get some of that information from history. So it's got a loss of sodium, inability to retain sodium, but it's probably got activation of its aldosterone system. So it's trying really hard to retain sodium. So I think those patients, if they were hypovolemic and hyponatremic, I'd probably be pretty worried. Hypervolemic or hypervolemic with a hyponatremia. I think that's where we're in trouble with kidney and heart. Doesn't really answer the question. Sorry. I just go by the number. I'm sure the criticalists have a more advanced way of using it, of calculating it. So what about if we've got a dog that has stage C degenerative mitral valve disease, which means what?
They've had an episode of congestive heart failure or are in congestive heart failure.
Yes, perfect, exactly. So we've got a patient with stage C, has been on furosemide for 6 months with pimobendan, had 2 days of vomiting, same presentation, and came in with a creatinine of 400, tachycardia, and an increased respiratory rate and a nasal drip. How are we going to manage this patient?
Difficulty.
Well, let's talk about what's going on here. We've got an azotemia, but we've also got volume overload.
I mean, you check blood pressure because that's something that you can manage to reduce the preload and and improve renal function.
I'm gonna challenge you a little bit on that.
Afterload.
Sorry?
Afterload.
Afterload, good. That's better. It's a lot of people sort of put preloaded blood when you're sort of talking about blood pressure. Often people haven't made the distinction between arterial blood pressure, which is what we're actually measuring, and venous blood pressure, which is, I think, really important in these congestive heart failure patients or any heart disease patients, because you can have quite profound hypertension and hypovolemia in these patients if they're on furosemide, or you can have really profound hypotension with really profound increased preload. So if you've got systolic failure, you've got huge volume in your venous system and no volume in your arterial system. So high blood pressure doesn't necessarily mean increased preload, and low blood pressure doesn't necessarily mean low volume, if that makes sense.
Yes.
Yeah. So there's very little transference of pressure from the arterial system to the venous system. So if you've got hypertension, it doesn't mean anything, because they all go through the capillary bed. There's actually no kind of vessels connecting to each other.
Very few people, in my experience, will measure central venous pressure.
Very few. It's really hard to do accurately in dogs.
The few times that I've done it, which is only a handful, or less than, it's been very useful. The other thing is clinically, because you can see it by assessing jugular distension, jugular refill time, and the other thing for dogs in lateral recumbency, but was it the lateral recurrent tarsal vein, the one that comes over the hock?
Right. Yeah.
Just lift the leg up until it collapses. Can give you an idea of a crude idea of what's happening.
Venous pressure. Yeah. And that gives you a marker of preload. but not after load. So that's not predictive of blood pressure. Often people look at the veins and go, oh, I've got great blood pressure. No, not the same. And it's a really important distinction because in this dog, we've got increased preload, but we've also got either the kidneys not being perfused. So GFR has dropped significantly. We can say that definitively from the creatinine level. So either the kidneys aren't getting enough blood flow or there's not enough nephrons to get rid of the blood. So how are we going to manage this dog?
Right.
Blood pressure is low, I should say. So blood pressure is 7. Systolic blood pressure is 70.
But the venous blood pressure is high.
High.
Yeah, so
Oxygen.
Yes, great. Good start. Yeah. So this dog's been vomiting for 2 days.
well, the electrolytes will be disturbed, probably.
Electrolytes will be disturbed. Yeah. So we're definitely going to we've done some bloods. And there's a hypokalemia.
Okay.
Yeah, well, we can correct.
Give potassium in a small amount of fluids, potassium. Severely dehydrated. Make sure it's having pimabendin injectable.
Good. Excellent. So where we need to focus, this is a dog that's in bad shape. And what we need to do is differentiate between, are these kidneys failing because we're not getting enough blood to them because systolic function is so poor that when we don't have sufficient blood flow to the kidneys, and that we can address medically. Getting nephrons working again is much harder medically. But if the cause of the nephrons not working is interstitial edema from volume overload, then we've maybe got a chance if we restore perfusion to the kidneys.
Urine-specific gravity would be fairly helpful here.
It would be, yeah. And also a report from the owners about whether the dog's been urinating or not, wouldn't it? So because this dog's been on frusemide, they should be used to letting this dog out to wee all the time. And if all of a sudden the last 2 days not weeing, either not getting its frusemide or no renal perfusion or no renal function. So injectable pimabendin is probably the best way that we've got to improve systolic function. And it's not uncommon in dogs with gastro to get dehydrated incredibly fast because when they're on frusemide, because they've got no mechanism to retain fluid. So we do get these kind of acute kidney injuries on dogs on frusemide when they get gastro. Those dogs will present hypovolemic. This dog's presented in heart failure. So I think we're not dealing with a frusemide-induced hypovolemic acute renal injury. We're dealing with an acute renal injury probably from decreased perfusion from poor systolic function because the dog got gastro and didn't take its pimabendin. So pimabendin is the primary thing that I want to do here. What other things can we do to improve renal function, to improve renal perfusion?
Try and minimize the losses, so like antiemetics.
Yes, excellent. Good. Yeah. Are there any other drugs that will help perfusion?
Do you want to like decrease the gradient between the afferent and the efferent arterioles? So like you use what's that called? It's an ACE inhibitor.
Mm-hmm. How does an ACE inhibitor work?
All I know is that it can sort of like decrease the like efferent arterial pressure so that between the two is not so big, so then the kidney doesn't have to work so hard.
Yeah. It's a good theory. So ACE inhibitors are great in their kind of renoprotective effects over in the long term. In the short term, when a patient is hypovolemic, an ACE inhibitor can actually decrease renal perfusion to the point that that nephron doesn't get any flow.
Mm.
So I actually usually recommend with ACE inhibitors to not use them when a patient's dehydrated at all, or when renal perfusion is compromised, because you might just exacerbate that. There's a few reports of ACE inhibitors causing acute renal injury in patients when you kind of, they come in heart failure, you hit them with a whole heap of furosemide, you drop renal perfusion, hit them with an ACE inhibitor at the same time. And the ACE inhibitor is the thing that kind of causes ongoing renal damage. So ACE inhibitors are great theory for quite long-term renal perfusion, but in an acute setting, I'd stay away from them.
Okay.
But it's a really good theory, and I like we want to increase delivery of blood to the glomerulus. How are we going to do that? We're going to give some pimobendan, so we're going to improve cardiac output. We're going to get a little bit more blood flowing there, but we've also got a systolic blood pressure of 70. It's not a lot of perfusion, not a lot of blood flowing to the kidneys. What can we do about that?
If you gave a nitroprusside,
what's that going to do?
You would get vasodilation, but I don't know if that would improve renal blood flow.
We're going to get vasodilation. It's going to help with is it capacitance? Is that word? Yeah, capacitance. It's going to help the venous system accommodate more fluids. It's decreased venous pressure, which is going to mean we get less edema, less ascites developing. But it's actually going to drop blood pressure a little bit. What's that going to do to the renal perfusion in the arterial side? Yeah, it's going to drop. It's going to decrease the regurgitant fraction. So we'll talk in the next case about nitroprusside. In fact, let's just talk about it now. So if you've got normal blood pressure and you've got a dog that's just completely decompensated in its congestive heart failure, the venous system is volume overloaded and we're starting to get edema develop. If you increase the capacity of the venous system with nitroprusside and you decrease blood pressure slightly with it, you're going to get decreased afterload, meaning the systolic function is going to improve and we're going to get better cardiac output and we're going to get less regurgitant fraction. So in that kind of edema state, nitroprusside is a good option as long as renal perfusion is good. But if renal perfusion is poor, you can't use it. Sorry, you got my fault.
So if you're saying there's hypotension, you have to address that because that will worsen the case. So had cases like that and it's really going to cry, maybe give one bolus and see what that does. But then it's like a fluid because like you need to address the hypotension, otherwise that will kill the patient.
Yeah, but this patient's already volume overloaded. Where's that fluid going to go?
Well, so can you use, then would you use half strength? Or I
wouldn't bolus this patient. What other mechanisms do we have of addressing hypotension?
Noradrenaline.
Good. Yes. What else?
Oh, dopamine.
Good. We got there.
Dobutamine, maybe less arrhythmogenic, maybe.
Good. Yeah. So there was a review on which one to use. Dobutamine has less positive inotropic effect than dopamine. So dopamine is the recommended choice of the two because it's got positive inotropic effect as well as the effects on the peripheral adrenal receptors. So pimobendan is the best of the positive inotropes to improve cardiac output. If you need more, then I would reach for dopamine over dobutamine. So then last case, because we talked about the nitroprusside one, I'm going to switch over to a right-sided congestive failure. What extra kind of complicating effect does a tense ascites have on the heart?
if there's much of an increase in abdominal pressure, it's going to reduce the preload to the heart, the amount of venous flow into the heart.
Exactly, yeah. So we get this kind of, we've already got volume overload in this system. We've already got congestion. And then all of a sudden that congestion gets to the point that it actually almost limits itself and decreases venous return to the heart because it's pushing on the cava. So then all of a sudden the blood going back to the heart drops off and we get decreased preload in that kind of thoracic cava, but we've actually got profoundly volume overloaded portal venous system. So that adds a little bit of a complication. What are you going to do about that? What mechanisms do we have to manage that will improve venous return to the heart and therefore renal perfusion?
In the acute setting, you could drain a lot of fluid off the abdomen.
Excellent. Perfect. So if you've got a patient with an effusion, pleural or peritoneal, because the kidneys just don't work that well, the frusemide just isn't going to be as effective. There's less nephrons for the frusemide to work on. So if you've got an option to centese rather than rely on diuretics in a patient with concurrent heart and renal disease, you should centese. Take some of the fluid off. And then you restore venous return to the heart, which is going to improve renal perfusion by improving cardiac output. And then you can address whether the kidneys are the worst problem or the heart's the worst problem once you've stabilized that side of things.
Anna, what's your like with these patients, the ones that have ascites? Because I can't find this anyway. How can you, like, how much fluid do you drain? There's no this thing. And do you cause more damage by draining more fluid? Like it says just therapeutically fine, but then with respiratory, it's easy because you can monitor the respirate and figure what's therapeutic. But with ascites, like I've had patients come in with like liters of fluid in the belly, big breeds.
Yeah.
And then I don't know how much to drain. It's always by doing more harm by draining too much. Like I don't know and can't find any information where there's anything set. Like how do you decide how much fluid is enough?
So if we're doing chronic drainages, so if we've got, say, a dog with like tricuspid insufficiency that's comes in every 4 weeks for its abdomen to be drained, I drain a lot. And in that more chronic management kind of setting, I would try and rely as heavily on diuretics as I could. So frusemide, spironolactone, as whatever I could use. And then once I'd maxed out the capacity of those, then you do centesis kind of as a last resort, just because of the challenge to quality of life. In those patients, I take every drop out because the more you take out, the less they have to come, less frequently they have to come in. In patients that present in an acute setting, I'm a little bit more conservative. And in cats, I'm quite conservative. There's reports of cats, if they've got a tense ascites, and you know they don't tell you anything's wrong until it's tense, and you drain a whole heap of fluid out of their abdomen, their portal system goes and they get such an acute drop in venous return to the heart, you can actually tip them into heart failure or sudden death. In cats have this suicide ventricle, and if venous return drops very acutely, their heart stops. So cats, special situation, and in an acute setting, I often just get rid of the tension to restore venous return and then move on to managing with other strategies like diuretics and things. But in this sort of situation where we've got concurrent cardiac and renal, and I'm thinking the diuretics aren't going to be very effective, I'm going to probably take out most of it unless it's a cat. We better wrap up there. We covered a few different scenarios. Has anybody got any questions?
Do you have a paper that you recommend to read about, between like arterial, venous, capillary bed, like just, I guess, learning like the physiology? Because I tried reading Edinger and it's really overwhelming.
Yeah. Honestly, the cardiac section of Edinger is very detailed for an internal medicine book. Let me have a think about that. Because I studied medical science before I did vet, so I've got human physiology textbooks, which are excellent.
Mm.
I think, Josh, do you have a good physiology textbook?
I was going to say Guyton and Hall is pretty good, and
Yeah.
also it's Cunningham's. So, but both of those are like good for that kind of stuff, I think.
I found Cunningham's easier to read, but not as detailed as Guyton and Hall. But I would
think
Guyton and Hall are far more detailed. Yeah.
Yeah. All right. So we've got an update coming on mechanism of action of abradine and something else I was supposed to do. I may not ever get that. Oh, no, it's gone. If anybody remembers what I was supposed to do, let me know. Otherwise, Jeff will let us know what the mechanism of action of abradine is. And we'll see you in 2 weeks for Cushing's disease and diabetes. Or no, corticosteroid responsive disease and diabetes.
Awesome.
Awesome.
Thank you.
Thank you.
Have a good day.
Yeah,
Have
you
fun in the
too.
snow.
Ooh,
Thanks.
yeah, thanks.
Thanks, guys. See ya.
Bye.
See ya.